Welcome everyone to Mayo Clinic Q&A. I'm Dr. Helena Gazelka. The Mayo Clinic Platform aims to use technology, big data, and artificial intelligence to make connections. The goal is to transform healthcare and healthcare delivery to meet patients right where they are. The person leading this initiative is Dr. John Halamka, a self-described physician, farmer, and fungi master, and he's a pretty fun guy too. Laugh, John.
Okay.
I am pleased to have Dr. John Halamka, the president of the Mayo Clinic Platform, join us today on Mayo Clinic Q&A. Hi, John.
Hello, great to be here.
Thanks for being here. Now, John, I've always said you have a really interesting story. Would you mind giving us your little elevator speech about your career and how it's led you here?
Well, sure. And of course, this is a very peculiar story, as you say. So I grew up a latchkey child in Southern California in the 60s. And back then, the defense contracting industry was sort of the Silicon Valley equivalent of California. And I would, as a youngster, wander around dumpsters pulling electronics that our defense contractors threw away. Back then, there was no security. So I taught myself analog and digital technologies. By the age of 12, started building microprocessors, sold computing systems when I was a teen, and said, I bet someday this will be important for medicine. And so one of the things I designed was for the Department of Neurology at UCLA, a way of gathering brain signals and then signal averaging them. And funny story, sold it to them when I was 14 or 15. When I went back there as a resident at age 30, they were still using it.
Wow, what an auspicious beginning.
There you go.
That's amazing. Well, John, share with us what we mean by the Mayo Clinic Platform. Is it an entity, a concept? How do you describe it?
Well, of course, you can look at platforms in many ways. So let's think for a moment. Back in the day, when you wanted to rent a room, you would pick up the newspaper and you would look in the want ads. Well, then some notion of, well, how about Airbnb? We'll have people who want to rent rooms and people who have rooms, and we'll bring them together in a platform. And so really, a platform is a set of digital components that bring together consumers and producers. And so what does that mean? There are those folks who create algorithms and knowledge. There are those folks who are able to deliver care in a virtual way. And there are those, of course, who need care. So platform is a series of technological components, but also people and processes that enable this to happen at very large scale, just like Airbnb enabled room renting at a very large scale.
That is really interesting. That's a nice comparison. I would prefer if you'd use something like people who want to sell things and people who want to buy them, because I do like to shop online. I think that's a great use of technology. John, tell us how the Mayo Clinic Platform is helping both patients here at Mayo Clinic and globally.
Sure. So one of the things Mayo Clinic has done so well is assemble the best specialists to give the highest quality care. But of course, it's typically at destination medical centers. And what if you want to deliver care to folks we've never reached or international locations? Well, you need new digital delivery mechanisms. So for example, we've created advanced care in the home, the ability to deliver advanced Mayo care that's serious and complex in your living room. And that's something that we've done in Florida and Wisconsin, but we're expanding nationally and now internationally. We've created AI algorithms, and those AI algorithms are things that can be accessible on devices or your phone to deliver Mayo quality expertise to a patient, to a consumer, without them having to travel. And these are just a few examples. Over the course of the next several years, there'll be dozens of these kinds of things.
That's fascinating. Would you be able to give us an example of a patient being helped by this, a treatment that's improved, or a disease state that we're treating better?
Well, sure. And so with our advanced care in the home, we have been able to rapidly detect changes in patient condition and then make adjustments in their care plan to ensure their wellness. We've done this now with over 100 patients, and it has turned out to just work extraordinarily well to have this patient remote monitoring connected to Mayo Clinic experts and then deliver continuous care. It isn't just you're calling your doctor for advice. No, this is continuous Mayo monitoring in the home. And we've had story after story of good outcomes and better patient satisfaction because we did that.
I was going to say, John, I would think that that would be a specific benefit, that the patients would really feel safer and would also appreciate having care in their home instead of in a facility.
And I'll tell you that the patient satisfaction has been extraordinary because when you go into the home, it isn't just treating the patient, it's treating the family, it's treating the entire social situation. And so we've had examples where we've looked at, oh, well, the family has a lot of complexity. Let's treat the whole family unit as part of a return to wellness. So you're absolutely right. It worked out so very well.
It's wonderful. Are you using this for COVID patients at all?
We are. And of course, it wasn't initially intended for COVID patients. And sometimes you could say it works actually better for not COVID patients because you keep the immunocompromised or those who are elderly or have multiple diseases out of a place where they might encounter COVID. But during the surges, what we've seen is you've run out of space in hospital facilities. So treating COVID at home has worked. And we've been able to do remote infusions of things like remdesivir or other IV drugs in the home. And we've been able to, in effect, enhance the patient's experience of getting COVID treatment without them having to leave their homes.
That's how wonderful for a disease state where we're trying to keep people socially separated as well. That sounds great.
Absolutely.
John, can you tell us a little bit about artificial intelligence? I feel like we read and see this term everywhere in relation to everything from healthcare to bank accounts, pretty much everything. Can you tell us if this is part of your platform initiatives and where do you see artificial intelligence taking the current healthcare system?
Sure. So artificial intelligence, very simply, is just pattern matching. So why is it as an emergency physician, which I am, I can look and say, oh, you're healthy or not? Well, it's because I've seen thousands and thousands of people, and I just have picked up over thousands of patients' ability to look at a pattern and say, oh, this person's really sick. We have to get this person treatment immediately. Well, artificial intelligence just simply does that to a much larger scale. And let me give you an example. If you're an ophthalmologist in your life, you'll look at about 10,000 retinal scans, pictures of the inside of the eye. Well, recently we've worked on an algorithm that has 1 million images as part of an artificial intelligence algorithm. So does that mean the algorithm is smarter than a doctor? Well, no, it just has more patterns that it has looked at. And therefore it turns out to actually be able to detect things humans cannot. One interesting development from Paul Friedman in cardiology is he's been able to look at COVID-infected patients and their EKGs, their heart tracings, and with a fair degree of certainty, he can diagnose a COVID infection from your heart tracing. A human can't do that, but a computer trained in pattern recognition can.
Yes, I was going to mention too that work in cardiology. It has amazed me the work that they've been able to do and the predictability of ECG or EKG readings.
Right. So looking at future atrial fibrillation, progression of pulmonary hypertension, or evaluation of your even ejection fraction. How well is your heart pumping blood, which normally takes a very complicated test, but we can do that from the ECG by looking at the subtle patterns that only a computer can detect.
John, there are still those that fear more technology and are concerned about how artificial intelligence can be used both equitably and responsibly. What would you say to that?
I would say those concerns are quite justified. And so let me use an example from Minnesota. Imagine we took 10,000 Norwegian Lutherans and we developed a model of disease treatment. And then we took that model and we brought it to Spain. And of course, I just made that up. Now, is it going to
Sounds like Minnesota, though?
Yeah. Is it going to work? Is it going to give too much care or too little care? The answer is we don't really know. And so it's really important that we understand when we develop an artificial intelligence model, that we understand the ingredients that went into it and its fitness for purpose. So what we're doing through Platform is developing a means of, it's a bit like a food, an ingredients label and a nutrition label. This algorithm was developed with these ingredients, and that you could look at race and ethnicity, age, gender, geography, and that kind of thing. And here's really where it's fitness for purpose. I mean, again, wonderful to use 10,000 Lutheran Norwegians if you're evaluating Lutheran Norwegians. There's nothing wrong with that. It's just using it the correct way. And that's why this labeling that we're doing, and we will suggest become a national approach, will really help us use AI algorithms for the right purpose at the right time.
That makes sense to me, John. One of the comparisons that I could think of in healthcare and in medical literature is that, sometimes we will hear people say, well, I don't know if that study applies to my patient or if that data applies to my patient, because those weren't really the people in the study.
Well, that's exactly right. So my wife, who's Korean, was diagnosed with stage 3A breast cancer in December of 2011. And of course, the standard treatment for cancer is for all humans, not Korean females with certain other disease states or genetics. So to ensure she got the right treatment, I had to do significant data analysis. And I didn't use just Korean women. I looked at Asian women in general to tailor her care plan. So much of platform is exactly as you say. If we are going to deliver advice, let's make sure it's customized to the person, their geography, the time of year, all those other variables.
Well, I have to say, John, that your wife selected her husband well for that particular task.
Well, excellent. It's worked out okay so far.
That's right. What are some of the other unique technologies that are being used in the platform, John?
So much of what we need to do is gather novel kinds of data and assemble them. And so that we have, over the last few years, seen a huge rise in the number of wearable devices or devices in your home that generate information about, your blood pressure, your pulse, your glucose level. But we're even starting to see some very unique devices come into the marketplace, such as there is a wearable from a company in California that can detect a menopausal hot flash 5 minutes before it actually happens. And it turns out there's just changes in the skin conductivity. Or there is a company in the UK that makes a device for those who wear colostomy bags to look at the output of their colostomy and to predict when they'll need a new bag. So I tell you this because there's literally hundreds of new kinds of devices generating new kinds of data. The key is, how do you take that data and turn it into wisdom? And really, platform is about partnerships and collaborations with companies around the world. So we'll take the new kinds of data and then be able to synthesize it into action.
That's really interesting. I'm wondering what you say to those who are concerned about privacy. So we have an electronic health record at Mayo Clinic that joins in with other health records, obviously, as you know. And there are some people who are concerned about how their data might be used, whether others are able to see it. How do you keep the individual data safe in a virtual environment?
Sure. So privacy is foundational. Privacy cannot be added after you've already engineered a solution. It has to be there at the very beginning. So a few things we've done. All the algorithms we develop are done through what I'll call de-identified or anonymized data. Mayo Clinic has partnered with leading companies to create the best-in-class de-identification methods. And what do I mean by that? Well, our United States laws would tell us if you remove the name and if you remove the address or the phone number, that's de-identified. Well, what if I do all that, but then the note says, this Minnesota senator? Well, that's not exactly de-identified, is it? And so we have had to figure out, again, using artificial intelligence and natural language processing techniques, how to take the information out of the record that could be used to easily re-identify that record. But still, even after all that de-identification, keep the data useful for algorithm development. Once we've done the de-identification, we put it in an encrypted container that only Mayo Clinic can access, and we run algorithms against that. And we're very, very careful that the data is always in our control. And so if it's de-identified, encrypted, and always in our control and never shared, that protects privacy, but it also ensures that we use the data ethically. And we're always very transparent with the patients about how we're going to use it and where their data might result in new cures and treatments. But we, through a new consenting process that Mayo is working on this year, will even give them more choice. So they're always in control.
John, what you just said makes me think of something you said earlier. So we were talking earlier about your wife being a Korean female of a certain age with a certain stage of breast cancer, and also the need to be sure that data is inclusive of various ethnicities, sex, etc. So how, if you de-identify data, do you make sure that your studies have the appropriate individuals in them without compromising privacy?
Well, absolutely. So you asked a brilliant question, because generally it's okay to leave certain things like race, ethnicity. Maybe we can't have birth date, but you could have age, right? And so we use this concept we call a bin sized, which is to say, leave enough data there so it's still going to be useful for reducing bias in the algorithm development, but make sure that every individual record is ambiguous enough so that there's at least 10 people in the study like that. So the example that I give is Provincetown, Massachusetts. Turns out to be a place where there are not a lot of Black Americans, not a lot of Black American females. And so if you gave a birth date and an ethnicity and a gender, it actually could be identifying, which is why we have to just say, oh, it's age. Or instead of Provincetown, we say the Cape, and those are ways where the data could still be useful, but not re-identifiable.
Well, that makes sense to me. Look ahead, John, and tell me, what do you see coming down the pike, and what will healthcare look like in the next 5 to 10 years or so?
Now, of course, there will always be in-person care, which is empathetic and personal. But I think COVID has taught us that working at a distance is actually effective for many things. So I think what you'll see is all forms of care. And whether that's the simplest, like, oh, look, it's a spot. Is that cancer? And I take a picture and I send it to a algorithm which looks at other spots and says, oh, it's probably fine. Simplest kind of virtual interaction, to a complex interaction like a hospitalization at a distance, to, hey, even remote surgery at a distance. We'll have a whole spectrum of connected virtual care experiences, and the technology and the policy will support them. But more importantly, COVID has taught us culturally that it's actually okay to do some things at a distance. So my prediction is we're going to see many more home diagnostics and many more home treatments as a result of our COVID experience.
Well, that's really interesting. I was just going to ask you what you thought we've learned from the COVID pandemic that we might take with us going forward. And I agree, we have done many more virtual visits. Just in my own practice in pain medicine, I've entered that reality, and I can see how it's very beneficial to patients.
Right, but there's something else that's happened during COVID, and that is, Americans are inherently competitive. And so you've typically seen a lot of companies that say, oh, if I help you, that's, not going to be a great thing because I'll lose business. Well, what's happened during COVID is we've seen coalitions come together of fierce competitors working for the benefit of society with the domination of no one. And it's, how many times in history have you seen Google, Microsoft, and Apple join hands and work together for the benefit of all? That's happened during COVID.
Wow, that is amazing.
So it's all good. And we've learned that cooperation, collaborating and working together, even though we're competitors, is very powerful.
Wonderful. Any last thoughts you'd like to share with our audience today, John?
Well, sure. I know that as we talk about new technologies, we're always worried because change is hard. Will I lose my job? Will I lose my doctor? Will I lose the pattern of my life? Much of what I work on in Platform is figuring out how I can use technologies to augment the human experience, to reduce the burden on patients and providers, and to achieve new cures and treatments. So think of what we're doing as giving us opportunities to do what we've always loved to do better. And so I don't fear the future, I embrace it.
That's great, John. I like that. Thanks so much for being here today.
Anytime. Be well.
I know where to find you.
That's true.
Our thanks to Mayo Clinic Platform President, Dr. John Halamka, for joining us today on Mayo Clinic Q&A. I hope that you've learned something. I know that I have. We wish everyone a wonderful day.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on podcasts. Thanks for listening and be well.